morning, everyone, and thank you for joining us today to go over the Applied Behavior Analysis Provider webinar for our ABA providers. I'm going to pass it over to Lindsey Zieder, our Children's System of Care Special Project Manager and DD Manager, and Laura Nguyen, one of our managers in our Network Management Department.
Thank you, Tara. Good morning, everyone. Lindsey Zieder, I'm the Children's System of Care DD Manager. Happy today to talk about some ABA stuff related to codes and services, and really hope to provide as much information as possible so the team feels supported and identify some new things that we're working on here at the plan level. Laura?
Good morning, everyone. My name is Laura Nguyen, and like Tara said, I'm a manager in the Network Management Department. And so all the providers, most of the providers on the call today are on my team. There's a few who are in like the southern Arizona that wouldn't be on my team, but mostly you have Shanette as your provider rep, and I am the manager of that team. Nice to be here with you all. Thank you.
All right, so in terms of the agenda today, we're going to just give a brief description, and I'm sure you all know, a description related to ABA services and what some of the expectations are at the plan level. We'll identify the referral process in terms of supporting children and adults within the system of care, as well as review the codes related to ABA and the prior auth requirements. For many of you that are or may not be aware, there is an access meeting right now with all of the MCOs, in particular discussing code use and prior authorization. So if anything, we just want to make sure that the group is aware of some of these expectations. If indeed there's questions, please reach out, but we're essentially just educating from the system level related to some access requirements in that particular topic. We'll then talk about case management services, particularly the code utilization for our ABA providers. We'll jump into the tiered ABA model as just a refresher related to modifiers and staff that can bill based on the tiered model for ABA services. Laura will jump into pay and chase and some really important indicators related to what pay and chase means from the plan level, some expectations from the provider network as well. We'll then jump into transportation. So we recognize case management and transportation. Code and billing has been quite the discussion in the system. So again, these really are some expectations coming down from access and making sure that we give as much information as possible to let the ABA network know what you can and can't do related to these particular services. Laura will jump into credentialing as well as the fee schedule, just quick reminders related to how to access the fee schedule and what that means with our ABA network. She'll also talk about the AAA audits that are conducted here at the plan on a quarterly basis and what some of the expectations are from the providers that will participate. Also, just lastly, I know the majority of the group today is contracted with us, but in the event you're non-contracted or you know someone who's interested in being contracted with Mercy Care, Laura will review how to join the network and what some of those expectations are related to a letter of interest, as well as our network management resource page and who you can outreach if indeed there's any questions. We'll end with an introduction to a new work group that we're going to be starting here at the plan level. We're going to be doing biannual ABA meetings. Hopefully that's a great extension and way for us to support you guys doing the frontline work and making sure that here at the plan level that we really understand what that service delivery looks like from you guys in particular. And we'll end with questions. So a pretty packed agenda today. We're going to move pretty quickly through it. But again, please utilize those features Tara mentioned to ask any questions along the way. Next slide. Excellent. So for a brief description for the group here in terms of what applied behavioral analysis is, or ABA, it's also it's an applied science focused on discovering environmental variables influencing behavior. So treatment is based on socially appropriate or important behaviors for an individual, and will focus on social communication and teaching skills to increase behaviors that are helpful while decreasing behaviors that are harmful or could affect learning for the young people that we serve and or adults. So ABA, as a reminder, is a covered service for all Mercy Care members. Please note this is an expectation for all MCOs to provide ABA services to the network. This was a change happening several years ago, back in 2016. So please continue to be an advocate for those families and community members that are in need of ABA services and navigating through the system to ensure they can access that covered benefit. ABA services are coordinated through the child and family team or adult recovery team. We will talk about on the next slide, again, the referral process. We do encourage that teams are involved, but it is not a requirement at this time. We'll jump into that in the next slide. And lastly, please also note Mercy Care does follow the Access 320S Applied Behavioral Analysis Policy, which again is an expectation for all MCOs. So in the event there's any questions from the network, we're looking to see what some of those new policy updates have been, if any, as we update those yearly access does. Please click the link below. The presentation will be provided, and you can learn a little bit more about what that policy indicates. Next slide. All right, so as we were talking briefly about referral processes, a couple of things I just want to clarify. And for many of the providers on the phone, in the event you offer other direct support services, ABA really has a special carve out in terms of what the referral process looks like. So in particular, it is a no wrong door service. So what we mean by that is in the event we have families or members requesting applied behavioral analysis, we want to ensure that those services are offered even if there has not been a referral from an assigned behavioral health clinic or child and family team or adult recovery team, right? So if you're having families calling you directly or individuals requesting the service, we do give you guys permission to move forward in assessing whether that service is appropriate. And throughout the course of treatment, one thing we strongly encourage is if you identify that the individual you're serving could benefit from some additional covered services. And these are services you don't provide. So an example could be case management or psychiatric services, therapy, family support, right, as we look at covered services. These are not something you provide. Please continue during the assessment and treatment planning process that you're assessing for the importance of these services and helping to connect the families to that service provider. So a couple of options could be connecting to Mercy Care member services and finding an assigned clinic within the member's geographical region. If the family has a preferred provider and they would like to go to them to receive services, please just continue to extend a hand and walk them through the system to make sure that we can get them the needed services. Another thing I just also want to highlight is in the children's and adult system, we have some really clear requirements related to expectations in serving members. So an example is if we have crisis involvement or if we see increased, emergency department utilization or inpatient utilization, as a health plan, we're required to email the service provider and help us develop a discharge plan and to meet particular requirements per access related to those levels of care. So if we don't have an assigned clinic in place and we're seeing some really high utilization of these particular services, we will ask the ABA provider to help us treatment plan and do some discharge planning. If that's outside your scope, again, these are expectations for our clinics. Please get the families connected and the individuals connected if indeed they need that support. So that's one area in which you'll get referrals, right? Direct calls from families or just people maybe doing Google searches and finding you because there's capacity. Again, please assess to get them connected. You also may receive referrals from our assigned behavioral health clinics. So our child and family teams and our adult recovery teams are expected to assess for medically necessary services. If they determine ABA is appropriate or something they want you guys to consider for the individual, you will receive referrals from that network as well. We do have a list of our providers on our website under our provider tab or our provider portal search. Please, again, there's many ways in which you can support families in getting connected. If you have questions on how to do this, please outreach us here at Mercy Care and we'd be happy to support. Next slide. Great, thank you. All right, so this one we're going to be talking about codes and prior auth. So for a couple of years now, more so effective November 1st of 2019, prior authorization was required for the new CPT ABA codes 97153 through 58. As you guys notice, we do not prior auth our assessment codes 51 and 52. That is part of just our access to care standards. We want to ensure that families and individuals will have access to ABA services, again, as we mentioned in the prior slide, and that we're assessing whether the services are appropriate within our access to care timeframe. So we did remove the prior authorization for that requirement. We do, please note, ask for prior authorization for treatment. 180 days is our review timeframe. So please just keep an eye on, for one, tracking that code utilization, making sure we're coordinating and submitting authorizations in a timely fashion, and we're utilizing the correct prior authorization form. We do have one in particular for ABA services. The link is here. It's also on our website. Please make sure you're utilizing that when you're requesting services. I do want to just give a quick caveat to the providers that are not contracted. We request prior authorization for all of the codes, so inclusive of 51 and 52 assessment. Again, when you're contracted, we don't. We did forget 2 T codes here, but we have, as part of the new CPT code set, we have the T codes. Those also require prior authorization. So please just make sure you're paying attention to some of those disclaimers for Mercy Care in particular. I do recognize, and as I put my provider hat on, other MCOs have different prior authorization criteria. That is something, again, as we're meeting with Access and all the MCOs to figure out a simple way for this to happen for you guys at that provider level, how you're coordinating services across plans, and trying to create some simplicity. But I do just want to highlight this is the Mercy Care expectation as of now. Next slide. So case management services. So there has been a lot of questions, and I appreciate a lot of the folks on the phone and the advocates in the ABA service arena to really bring this to not only the MCO level, but also the Access and DDD level. There is also a lot of confusion here, right? When it comes across other payers, other plans, there is some providers that can bill case management to the plan, and there's some that can't. I do want to note that we here at Mercy Care do allow ABA providers to bill P1016 with the case management code. So this, for a brief description, it's a 15-minute billable code, and it's a supportive service designed to help provide oversight and enhance members' care related to their treatments and making sure that treatment's effective. So I did list out a couple of activities down below that could help just as you guys start to cross-reference the work that you're providing to whether case management's appropriate or not. Please defer to some of these activities we've included on the slide. We also have some provider communication we rolled out a couple of years ago also on our website. So tons of resources to help outline whether Mercy Care does or does not, but I do want to highlight Mercy Care does pay T1016 for our ABA providers, and that's inclusive of provider types BC and 77. So BC, as a refresher, is board certified staff that will be billing. So that is our BCBAs or LBAs that will be billing, and our 77 is an outpatient provider type. So if you fall into one of those categories, please make note of this slide. Again, questions, please elevate those to us. But this is what Mercy Care allows at this time. Next slide. All right, so in terms of our tiered model, as a refresher, this model became effective July 1st of 2020. So it's been there for a couple of years, almost 2. We're really proud to see the tiered model being utilized in the system. I do recognize there's a bit of confusion, right, in terms of, again, other MCOs and the way Access defines these modifiers and how Mercy Care is utilizing them for the tiered model. But just as a refresher, these tiers are based on a level of experience and education. So definitely something to make note if you have staff falling in these areas. It's really based on what are they providing in terms of the service delivery. So let me give an example. So if your agency has BHTs or even RBTs, I think the majority of you guys have RBTs on the phone, they're going to fall under modifier HM. So the description for this modifier in particular is indicating less than a bachelor's degree. You may or may not have staff, whether a BHT or RBT be defined as that education tier. That doesn't matter to us here at Mercy Care. What I want to see is that if your staff are providing that direct treatment that are considered an RBT or BHT, they're utilizing modifier HM. In terms of the middle tier, second tier, the way that we're considering this, the trainee, the master level staff, or the assistant BCABA, those are relative unicorns here in the state. We don't see a lot of that middle tier position anymore. But in the event you have any trainees or staff completing their master's program, and they're providing that supplemental oversight to the BCBA, training of the techs, or implementing treatment, they're going to use the modifier HN. Again, we see the description of bachelor's. What we want to focus on is what they're providing. The BCBA has their own modifier, HO, so we want to make sure that we're capturing that position in terms of supervision and service plan development or whatever that may be. Make sure that you're utilizing HO as the modifier. And lastly, our BCBA-D, so our doctorate position or even our LBA is going to fall under that level, and it's going to be utilizing modifier HP. This was deployed a couple of months after our model came out, just based on Access continuing to redefine what the modifiers will look like. Please, again, make note of this slide. If you have questions, reach out. I do believe that there's a lot of comfort in terms of utilizing these modifiers in the system now, but definitely something that we have a strong focus on when we're looking at the tiers. Next slide. All right, Laura, thank you.
Right. Thank you so much. So I just want to, a lot of you are familiar with pay and chase rules through Access. ABA services are part of the pay and chase rules. However, Access is the prior of last resort. Access is the payer of last resort unless specifically prohibited by applicable state or federal laws. This means Access shall be used as a source of payment for covered services only after all other sources of payment have been exhausted. Providers should always bill the primary insurance first and then submit the claim with the COB to Mercy Care. Providers who are not contracted with the primary insurance still need to submit the claims to the primary even if a denial is anticipated. Mercy Care will then attempt to pay and chase with that primary insurance company to recover any monies back that we can. But it is your responsibility, even though we have the pay and chase rules and we have a company that does that, it's your responsibility to still bill the primary, even if you know you're going to get a denial. Mercy Care needs to see that, and then we will pay a secondary, and we will pay the claim. Failure to bill primary insurance could become an issue during program integrity audit with providers. So please, I know in the past we have had some that we are paying secondary without the COB from the primary, but we have in our system set up not to do that. You have to bill the primary. We then will pay and chase if that was denied because you weren't contracted with the primary, but it is your responsibility to bill them. Next slide. Lindsay, do you want to do this one?
Absolutely. So this was in partnership with some of the case management co-use and questions related to transportation. So again, really important that we have a keen focus on what the expectations are related to transportation for the ABA provider network. So according to Access, again, the code that would be utilized for transportation is A0160, which is considered non-emergency transportation. So the caseworker, social worker would essentially look at the mileage associated with the travel. The first 25 miles of provider travel is included in the rate and calculated for each service. However, if the provider exceeds 25 miles, they can bill the additional miles traveled by utilizing, again, that code that was just previously mentioned. CPT code A0160 does not require prior authorization. So please note that is a Mercy Care expectation. I, again, recognize provider hat that other plans have different expectations. Please highlight that section in particular to note that Mercy Care does not require authorization. So BCBAs with a category of service 31, registrations are allowed to bill for transportation when the trip exceeds 25 miles. So a couple of notes here, please outreach Access if you're unsure for one if you're registered as a category of service 31. Also outreach if you have not, if you do not have category 31 and you would like to see if this is possible for your provider type and agency to add so you can bill the transportation code. However, if Access adds the category of service to your profile, please reach out to your network consultant here at the plan. I think the majority of you have Jeanette, but please outreach to let us know that the category of service was added to your profile, and we'll complete a form and add it to the provider network within Mercy Care. So please highlight this section. If you have questions, concerns, Access is a great support. Keep us updated on what that process looks like. And again, we'd be happy to answer and support with any questions you may have. Next slide.
All right, thank you, Lindsay. So we require at Mercy Care all BCBAs and psychologists must be credentialed with Mercy Care. So if you guys bring on a new BCBA or a new psychologist, you must get them credentialed with Mercy Care, and I'm talking about our contracted providers. If there's a few of you on the phone who are not contracted, credentialing is not a requirement. You can outreach us if you have questions about that. I want to focus on contracted providers right now. So if you bring on a new BCBA or a new psychologist, you must credential them with Mercy Care. Providers, they have to be credentialed and have an effective Mercy Care credentialing date before they can see one of our members. So keep that in mind, please. Here are the forms that you would need to fill out and submit to us. The AZHP practitioner data form. You would need to submit the BCBA certificate license or that psychologist certificate license, a W-9, and the certificate of insurance for the provider group. You would submit all that to the Mercy Care Network Management at mercycareaz.org email box, and we would get them credentialed. It takes, you know, we ask for a 90-day notice so that we can get them credentialed into the claim system by the time they're ready to start seeing members. Credentialing is usually taking about 30 days right now, so just keep in mind that we do have that time frame. I realize that some of you on the phone are clinics, behavioral health clinics. So your clinics would need to be credentialed in that case. We do usually also credential your people, your individual providers, so you can send those forms in also. But if you are like a 77 behavioral health clinic or an IC clinic, the requirement is that you have your facilities credentialed. And so certainly reach out to us if you have any questions about credentialing. Please note though that if you are bringing in a new BCBA and you need them to start working right away, we understand that we can prior authorize non-PAR providers. Even if you get that prior authorization, you still need to credential these people. You can start seeing members with that prior authorization as a non-PAR provider, but we need you to be credentialed because you are a contracted group. All of your people should be credentialed. So please ensure that you're submitting these documents also while you're seeing members with a non-PAR prior authorization. We still need to get you credentialed. So please continue to send in these forms as well. Next slide. Here we have the ABA fee schedule, and I want to point out that the ABA does have its own fee schedule. So on our website, mercycareaz.org, you will always want to go into the Mercy Care web portal, not the REBA web portal, but the Mercy Care web portal. It's at the top of the screen on the first page of the website. Once you're in the Mercy Care web portal, you'll click on Provider Documents, and then it's on page 3 now, so you've got to be really careful because we have a lot of fee schedule in there. But you'll go to page 3, and it's showing as the 2020 October 1st Mercy Care ABA rate. You definitely want to use that fee schedule for the correct rates for ABA services. Next slide. Appointment availability audit, the AAA. Access requires that we call providers quarterly and do an appointment availability audit with them. It's a questionnaire that takes about 3 to 5 minutes or less. Once you guys have completed a few of these, it gets really easy. You know, most of you on the phone have Jeanette as your provider rep. She will call you quarterly. She will do this quick questionnaire with you, and it is going to ask you if you receive a referral, are you able to get that referral seen for their intake within the first 7 days? Are you able to get services started within the first 21 days? Are you able to get them referred out for medications if that's needed to a different provider in 45 days? There's a bunch of questions. What is your after hours voicemail set up, or do you have after hours care? There's a bunch of questions. Once you get this webinar, this is a blue clickable link for standards for appointment availability. Providers on this call are required to be within the appointment availability audit standards. So you definitely want to make sure you're aware of these. If you're not within standards, if let's say she does a call with you, and unfortunately right now, because maybe short-staffed, we get it. We all know everyone's short-staffed. We totally understand. And you fail the audit. We work with you for several months to try to figure out a plan to not fail the audit. If you are so short-staffed and you know you're failing that audit, you should really tell us. You should reach out to Jeanette and tell us, or your provider rep, and let us know that you are not meeting the standards. And then we can really work with you to figure out what's the best for your agency on what to do at that moment so that you aren't going to fail these audits and potentially be put on a corrective action plan with Mercy Care. So reach out to us and keep us in communication. If you're not able to adhere to the standards, we will definitely work with you. So please just let us know. Next slide. Great. Here's some of the standards that I was talking about. So an initial assessment within 7 calendar days of the referral or request for that service. If a member is over 18 years old, the first service following the assessment should be within 23 days. If the member is under 18, it should be no later than 21 days after the initial assessment. And all following services no later than 45 calendar days from the indication of need. And then urgence. If a member is in urgent need, they need to be seen within 24 hours of that urgent need being identified. And that doesn't necessarily mean like you have to see them in person. It can be like, if you assess them over the phone and the urgency was resolved, somebody has to be available within 24 hours to take on that urgent request and get it resolved. You can certainly reach out to your provider rep if you have more questions about these standards. Next slide. Join our network. Like Lindsey had said at the beginning, probably most of you on this webinar today are a contracted provider, but if you know other ABA providers out there that may want to be contracted with Mercy Care, or you happen to be a non-contracted provider, you would want to send us a letter of interest to Mercy Care, a summary of your program with descriptions, including target populations, age categories, specific models of care, therapies used, along with frequency of programming treatment, and a W-9. Please submit that to Mercy Care Network Management at mercycareaz.org. You will get an automatic response that we received it. On that automatic response, it does say our network is closed, but that we will look at your request. Every letter of interest to join our network is reviewed by a contract negotiator, and so you don't need to worry. Even though it's an automatic response, it will be looked at and vetted. Next slide. Network management resources. We have a dedicated, Mercy Care is dedicated to helping all providers and members. Every provider that is contracted with Mercy Care has a representative. Again, most of you on the call today have Shanette. I saw Southwest. Hello. I know you have Dana. And then there might be some from the South who you would have either Chris Paquette or Sherry as your representative. And so hopefully you know who your representative is. If you don't know, please let us know. It's also on our website. And then non-contracted providers are encouraged to call our Claims Research Claims Inquiry, CICR phone number for any help or support. If CICR is unable to help you with any claims or patient or member information, they will forward that to me in network management, and I will find a rep to help you. Next slide. And then I'm going to pass it back to Lindsey. Thank you so much.
Thank you. This is something we are incredibly excited to start here at the plan, to really get to know each and every unique provider, but really talk about some big strategies and initiatives that we're all working on in different areas, hoping to bring together the experts on the phone. But we will be scheduling later on this year a biannual ABA work group. And so we're really hoping, again, to target all of our contracted providers at this point. We welcome you. We really want you part of some of these really deep discussions on how we can continue to support the network, our members, around education, opportunities, resources, and feedback. So a couple of brief ideas I put here, and I'd love to hear a little bit more from the group. But I'm hoping, for one, we can do some provider presentations, really hear from the network what particular services you're providing, age group, level of expertise, sort of, you know, the staff that make up your agency, where they come from, their walks of life, and what they're bringing here to the state of Arizona. We have some really, really excellent staff providing this level of treatment, and I'd love to share and connect everyone network-wise. We'd also like to talk about some quality improvement strategies and communication strategies. So how are we continuing to push the benchmark around competency, service delivery, quality management, communication oversight? How are we connecting with those that may benefit from ABA services? What outreaches and what strategies can we implement? But again, most importantly, how are we focusing on fidelity and quality? So lots of great conversations embedded in those too. I know some individuals are accredited by the Behavioral Health Centers of Excellence or have accreditations from other organizations. Love to hear, sort of what you guys are doing around some of that work. Probably most importantly, as we start to talk about capacity, we still recognize the workforce is struggling here in the state of Arizona, but nationally. We recognize next month that the federal emergency is going to be ending with access, and we have potentially around 500,000 individuals that will lose access coverage. So for one, we're trying to support those individuals if they need continued service. But we also recognize all of this ties into capacity. What does this mean in navigating our network? How are we increasing capacity, staff expertise, ties in with the next one, competency? What opportunities do we have to continue to, not only build capacity and focus on our communication, but also build some of the competency areas? One in particular, supporting our adults. We recognize there's not a lot of research, not a lot of training programs within our universities to increase that area of expertise. What can we do as the leaders of ABA here in the state to push the benchmark a little bit further? And again, we have some really great individuals embedded in our agencies. Love to hear what some of your thoughts are. This ties in a little bit with above, but how are we connecting with family and member engagement? This is a really critical component to ABA services as we start to train transition services, monitor fidelity with caregivers, or an implementation of the model. What can we do, and what measures or what opportunities do we have to discuss family and member engagement? How can we continue to have them part of the modality and keep them engaged in some really critical, important work done within the system? And lastly, we always have to talk about administrative reviews. Again, continuing to talk about the importance of prior authorization. We can start to look at some data around authorization timeframes if needed, or focus on particular providers. Data is always helpful, and I know that's sort of the key of the work that we do here in the ABA arena. So if data is requested, we will get some for you around prior authorization, codes, and referral. So lots of great conversations to come. Please look for the invite. Love to have you guys there. And if I have maybe 2 providers that want to start with a presentation, email me and we'll get you connected and get you ready for that presentation in our next work group. So that's it.
And that is all we have for you today. I really want to thank Lindsey and Laura for taking the time to present on all of this content. Thank you, Keely and Latoya, for joining us today, and Luis. We really appreciate your guys' collaboration and making sure our providers get the best content they need. And of course, thank you to all of our providers that joined us today, whether you're contracted or not. We really appreciate you guys spending a little bit of time with us so that we can help provide some additional information on ABA services. And with that, I want to say thank you very much for all you do to serve our members every day, and we hope you have a wonderful rest of your day.